Thank you, everyone. Once again, thank you to the organizers for inviting me and to all the people who've stayed on tonight. Thank you. So my talk today is on left main PCI, when one stent is enough. As mentioned, I'm an interventional cardiologist in Bristol in the UK. So left main PCI is not really just like any other bifurcation. There are some specific things that you have to be aware of. The left main supplies over 70% of the myocardium, and therefore the stakes are high when you're doing left main PCI. Other factors in terms of anatomy make the left main more challenging. The ostium can be angled differently to other vessels, other bifurcations. The size of the left main is usually large and can be highly variable. And there are two pretty important branches that come off the left main that you need to be aware of and taking care of. So what are the guidelines on left main PCI? So the American guidelines say that in patients with stable ischemic heart disease, significant left main, CABG still is 1A, however, or 1B rather. However, PCI can be considered if in selected patients where you can get an equivalent result, and that's a 2A. For my part of the world, the European guidelines actually a bit more positive about PCI for left main disease. So if there's a low syntax score of 0 to 22, PCI also has a 1A indication. CABG obviously has a 1A indication across the board, and then in intermediate syntax, PCI has a 2A recommendation. And I think this is probably well borne out by our data, because this is probably the most useful that I use to counsel my patients. If you look at this meta-analysis that was published in The Lancet in 2021, what it showed was that there was no mortality benefit of CABG over PCI at 5 years. The p-value is non-significant. And so what do I tell my patients? Well, the reality is, if you do have PCI for left main disease, 1 in 6 people will come in for repeat revascularization. But if you have CABG, 1 in 9 will come in. And similarly, the rates of spontaneous MI are higher if you have PCI. So if you have PCI, it's 1 in 17. But if you have CABG, you've still got a 1 in 33 risk of MI. And so I don't think it's as black and white as you know, some of what the social media publicity has been regarding Excel trial in particular. And I think the fact that PCI really can have quite good results is borne out by the fact that we're doing an increasing number of left main procedures. And this is UK data, and you can see that the left main PCI volumes are rising year on year. So what are our strategies for left main PCI? So obviously, you've got the two strategies, provisional or 2 stent. And then when you think about 2 stent, you've got DK crush, culotte, or tap as the main 3 strategies that you can go for. But what you have to be aware of is that not all left mains are equal. You have, of course, the true complex bifurcations, 1-1-1, or probably even your 0-1-1s, where both daughter vessels have significant disease. But your other bifurcations in the middle, you know, are probably lower risk and therefore could be treated slightly differently. So what does the evidence for left main PCI say? So this is the definition trial, which I think has been shown a couple of times this meeting, which looked at a randomized comparison of 2 stent versus provisional stenting in complex coronary bifurcation lesions. And they had quite clear criteria for what a complex coronary bifurcation lesion was for both left main and non-left main PCI. And so they randomized 653 patients to 2 stent versus provisional. And the results essentially showed that a systematic 2 stent approach was superior to provisional stenting. And provisional stenting was associated with a higher rate of target lesion failure at 1 year. Things to be aware of though, provisional arm, 22% actually needed conversion to a 2 stent strategy for treatment of the side branch. And the 2 stent strategy arm, nearly 80% was DK crush. So a vast majority of patients were getting DK crush and very few were getting culotte. And on the graph on the right, you can see that these are the 3-year results from definition which were published just last year. And what that shows is that if you survive until 1 year with no complications, after that there is actually no difference between the provisional and 2 stent arms. So the next trial that's been also discussed, I think, a few times is the DK Crush 5 trial. This was the 26 centers, 5 countries, and again randomized true distal left main bifurcation lesions, Medina 111 or 011, and into planned DK Crush versus provisional. And to be aware of here is that the operators in this trial were experienced DK Crush operators. And what this showed was that DK Crush was superior to provisional stenting for the primary endpoint. And this was true for both simple and complex left main lesions. So provisional stenting was associated with a higher rate of 1-year target lesion failure. But again, these were very experienced DK Crush operators. This is a Chinese group that was leading the trial. Again, from close to my part of the world, the European Bifurcation Club Left Main Study, EBC Main, which was published last year. This was 11 European centres, including the UK. Again, there were true left main bifurcation lesions, so true complex left main bifurcation, and again randomized to stepwise led provisional or systematic dual stent approach. And in the planned 2 stent arm, the majority were culotte or T or TAP, and that is really reflective of European practice, which is very much focused and heavy on culotte. The primary endpoint was a 1-year composite of death, MI, and TLR. And this showed that a planned 2 stent strategy and provisional stenting had actually had equivalent outcomes. Numerically, the provisional arm had lower number of the primary endpoint. However, the p-value was non-significant. And if you just compare the 2 recent trials, the 2 biggest trials that we have of left main PCI strategy, DK Crush 5 and EBC Main, they're all well-conducted studies, but things to be aware of, in DK Crush 5, 47% of the patients had bailout stenting of the side branch, and this is known to be a risk for suboptimal stent results. In EBC Main, obviously, the strategies were mainly culotte or TAP, and so a very few DK Crush. That might have had an effect on the outcomes. And most disappointingly, I suppose, in both trials, the use of imaging was really low, 42% in DK Crush, 33% in EBC Main, which I think is pretty concerning, considering, most of us are on our best behavior when we recruit to trials and do trial patients. And this is a meta-analysis that's been published fairly recently as well from the US. And what that is, overall, the findings have been that provisional stenting should be the preferred technique over 2 stent strategy when treating left main bifurcation lesions. But further randomized controlled trials comparing the 2 strategies should mandate intracoronary imaging, because otherwise how are we really reflecting best practice? So final study that I'd just like to highlight, this is the COBIS-3 registry. The reason I'm highlighting this is because one of the controversies in left main PCI is what do you do with the side branch, or in any bifurcation, but more importantly, left main PCI, what do you do with the side branch? So this compared patients undergoing provisional strategy who just had either provisional with that, and that was it, or provisional plus opening up of the side branch, so a kissing balloon inflation at the end. And what they found was that actually there was no difference in the two strategies. And again, this was true for whether it was a left main lesion, not left main, whether it was true bifurcation or not true bifurcation lesion. So just to finish off with a case, this is an 84-year-old gentleman who had a non-STEMI last year, 2 weeks after having a total hip replacement for a fractured neck of femur. He had a high sensitivity troponin of 146 and preserved LV function on echo. I haven't shown you the RCA here, but this was a non-dominant RCA. So these pictures were taken by a colleague of mine, and you can show that you can hopefully appreciate that there's a short left main and then a severe osteal LAD, calcific lesion. There's also an intermediate which has some disease of the ostium, and again a circumflex which again has probably a degree of stenosis of the ostium. As is our normal practice in my institution, he was taken off the table for discussion regarding options of treatment. And in view of his age, frailty, it was felt that PCI was preferred. So he came, placed on my list. So I took a 7-French JL3 guide. I can't actually remember why I chose for a JL guide, and I suspect that was the one that sat the best. Put cyan blue wires down all 3 branches, and then did an upfront IVUS of the LAD and the circumflex. I decided that I think trifurcations need to be brought down to bifurcations in general, and so we wanted to make things simple, and I thought that the intermediate would probably hang on, and the circumflex, which was a dominant circumflex, and the LAD were the 2 main vessels of concern. And you can see here that the ostium of the LAD in the red, that's got a concentric ring of calcium. The left main also has a degree of calcium, but it's fractured, and the circumflex is actually, while diseased, has a reasonable area, and I can tell you that the MSA here was about 6 millimeters squared. And so I decided that in view of that, I was going to go with a provisional strategy. So for predilatation, I took a 3.0 NC balloon and then a 3.5 NC balloon, and hopefully you can appreciate that there is some wasting in the NC balloon. And so based on the IVUS findings and the wasting of the balloon, I decided to take intravascular lithotripsy. This is a 3.5 shockwave balloon, and you can see that slowly the wasting improves. So on the left, it's still quite wasted, and with repeated inflations, this improves. And so I delivered about 60 pulses of shockwave in the left main to ostial LAD. Repeated the IVUS, which showed quite nicely that the distal landing zone was about, could be probably made up to a 3.0. The ostial LAD, where there was a concentric ring of calcium, has now fractured at about 11 o'clock. And the left main, again, has had some luminal gain. So at this point, I proceeded on with stenting. This is standard PCI. My preference is to use a Megatron in the left main, just for its radial strength. I had some geographic mismatch, so I put a 3rd stent in the middle. Did some post-dilatation and a good pot in the left main. And this was the final angiographic result. And this is the IVUS. In the interest of time, I won't go through it, but I can tell you that the IVUS showed really good areas and an MSA of over 11 in the left main. So what's in the future is drug-eluting balloons. We've got a centre in the UK in the east of England, in Norfolk, who are very keen on drug-eluting balloons. And they did the single-centre study of 148 patients of drug-coated balloon versus drug-eluting stents for unprotected left main disease, and showed that there was no difference in cardiac mortality, target vessel MI, or target lesion revasc. And so I'm not sure that DCBs are going to take over the stent strategy for left main, but maybe one thing that we certainly do a fair bit of is if we put a stent provisionally across the left main to LAD, we will often use a drug-coated balloon in the circumflex. So in conclusion, I think a heart team discussion and informed discussion with the patient is essential for all stable left main PCI. I don't think we should be doing ad hoc left main PCI. The approach depends a lot on the strategy that you're most comfortable with. Personally, my practice is that a layered provisional strategy is my default in most cases, unless there's a clear Medina 111 or 011 lesion in the distal left main. DK crush is my preferred 2-stent strategy, and that's really because of my experience and also the fact that I don't lose my LAD wire. I think it's important if you're going to use provisional that you have a Baylite strategy. For me, that's a reverse calotte. I think a good pot is really important to assist you in rewiring your side branch, which is usually your circumflex and is often angulated. I think you should consider final kissing balloon inflations to maintain access to a side branch. I think there is no evidence for or against, but you will be helping the next person coming along if they have to access the circumflex, for example, and you haven't done a kiss. It might be quite challenging. And I think intravascular imaging is central to assessing plaque burden, plaque morphology, determining 1 versus 2 stent strategy, lesion preparation, and optimizing the stent result. And so I'd really encourage you to image first, image during, and image last. Thank you for your time.